Thanks. Hi. I think this morning we've gotten a lot of great information, and we'd like to encourage everybody to ask questions. Let me just start off with hi. I guess the good news is there are a lot of options, and there are more coming, and there are a lot of different factors for individual patients. How much time do you allow to counsel patients? Because obviously there are a lot of things to think about, and we're all busy.
To counsel patients on PrEP?
Yes.
So I generally start with asking them what they know about PrEP and then go from there. So generally it's really answering their questions and 5 to 10 minutes depending on how much somebody might know about PrEP already. And then trying to task shift this off to our navigators or our social worker and ensuring that they are actually aware of PrEP and can do a lot of that counseling as well. Because if I have 20 minutes, to talk about other medical problems, like spending that 10 minutes would be important, but somebody else can also do that. And our staff are actually quite good at doing the counseling, in some ways better than some of the providers, because they take their positive.
Yeah, I mean, I see Mike is about to say something, but before we get to Mike, I think you have a great advantage in that you have a very knowledgeable and presumably extensive staff. But Jean-Michel, in France, how do you approach this? Do you have the same kind of resources, and how much time do you spend with your patients? Because I see you have 3,000 patients, so you have a lot to talk to.
Right. Well, so far PrEP delivery is really hospital centralized, and we're trying to involve GPs to deliver PrEP. And recently, actually in France, last June, GP were allowed to really prescribe and monitor people on PrEP, because one of the issues we're facing with PrEP now is, implementation, and we need to really upscale implementation. You've done a great job in the US. In France, we only have like 30,000 people on PrEP right now, and that's clearly not enough. So, beyond physicians, we're trying to involve nurses in our clinic and really to rely also on GPs to, take their part in this PrEP strategy.
Yes, so Mike, you look like you had something to say.
Yeah, Jean-Michel, so your team not only pioneered 211, you also have been looking a lot at prophylaxis against STIs with doxycycline. Can you tell us briefly about that? And then, Hyman, if you don't mind, make a comment about if you've been using that in your practice and in what settings.
Well, thank you, Mike. Well, with the the 211 regimen, now we have, experience since 2012, so a couple of years, and really we offer the choice to the PrEP participants or people asking for PrEP. And what we've seen over the years is that, roughly 50% would choose on demand, 50% daily, but eventually it's not that different. And we people can switch from one regimen to the other, and it works quite well once you have some experience in explaining. It takes a couple of some time to explain people how to do it and how to adapt their behavior to the PrEP regimen. But then it's quite easy, and people like that, and they know that they're happy not to take pills when they are not exposed to HIV. They don't have condomless sex, for example. Regarding STI prophylaxis, we investigated doxycycline post-exposure prophylaxis because we've seen in our initial PrEP studies such a high rate of STIs in this population, and we said we had to do something about that. And we thought doxycycline, for chlamydia and syphilis would probably be effective, and indeed it was. Not effective against gonorrhea, though, because there is already a high rate of resistance to tetracycline and doxycycline, across the globe. But I would say for this strategy, we are very cautious. So we do not use this strategy outside clinical trials right now. There are a number of trials ongoing, one in San Francisco and Seattle, one in Paris. We're trying to repeat this experiment on a larger population to confirm these findings, and especially to make sure that we are not, jeopardizing these antibiotics to treat STIs. And for syphilis, for example, doxycycline is the first choice in people who have penicillin allergy. So we don't want to spoil doxycycline, and we don't want to favor the emergence of chlamydia or syphilis resistance to doxycycline. So we are very careful with that. These bugs are different from gonorrhea. Resistance to doxycycline in chlamydia and syphilis is probably very difficult to select. It has not been seen so far, but we don't want to be responsible for that. So we are very cautious, and we are testing, other approaches for STIs. And I think that, the field is now moving towards vaccines for bacterial STIs. There are a lot of new vaccines for gonorrhea that are in development right now, even for syphilis. There is no reason we don't have a vaccine for syphilis. And for chlamydia, it might be a little bit challenging to develop a vaccine. There have been, trials which have failed, but I think we still need to try. So I would say antibiotic prophylaxis, it probably is not the way forward in the future.
Yeah, I'm not ready for prime time right now. So I think that may have answered your comment, Hyman, but you guys have a study there that you're enrolling into for that?
Yeah, so there's a study that's looking at use of doxycycline post-exposure prophylaxis for people on PrEP and people living with HIV. And in my clinical practice, I refer, because I work in these clinics, I refer individuals to that. Not everyone is willing or wants to be randomized to receive it or not. And so I actually have had some of my patients who may have had like 2 incident syphilis cases in a year. I've given them doxycycline PEP. And it's a limited number of people. But I think that this is something the community is aware of now, because it's sort of in the community, it's in discussions that people are having. And so I have used it occasionally. It's not something that I would say is widespread.
Right. No, good points. Henry?
Good. We have 3 or 4 more minutes. One important point that's come up in a couple of questions, maybe Jean-Michel, you could respond to, is whether or not it would ever be safe to use cabotegravir solely as an injection. I think that's obviously an important point to make sure that everybody's clear about. But why we have an oral lead-in, and whether we could ever treat patients without an oral lead-in.
Right. I think, Rafi would probably be more able to answer than me, but what I could say is that now in the extended study from the cabotegravir injectable agents, there is no more, no more oral lead-in. So the safety is good enough. Now we have a lot of experience with oral and injectable cabotegravir, and clearly the lead-in phase with oral pills is no longer needed, and it will not be actually required unless a physician would like to do it or patients would like to use it. So I think regarding the oral lead-in, we're pretty clear about what to do. What's great about these cabotegravir studies is that it gives also the proof of concept that you could prevent HIV acquisition with a single agent. We have data with TDF-FTC, it's a combination. There are a limited number of data with TDF alone, but the guidelines would say today it's a combination for oral PrEP. And clearly it would be great to have PrEP with the single agents. Rafi has highlighted a few limitations, and we clearly need to better understand why some individuals, despite a correct use of cabotegravir, had breakthrough HIV infections. And in some individuals, there was a selection of integrase resistance that may confer some level of cross-resistance to dolutegravir. So I think we need to know a little bit more, and with upscaling implementation of cabotegravir when it's going to be approved by FDA, which I think it will soon, we probably will have more knowledge about what to do and how to manage cabotegravir.
Yeah, we have 2 more minutes, but maybe I ask Mike Saag. Sort of the old time people probably would be a little bit worried about giving a long-acting drug before you knew whether there was tolerability, but it seems like now we have data. Are you comfortable with that?
Not quite yet, but all it's going to take is that N of 1 in your practice, and everyone will freak out. But we'll follow the data. I mean, that's what we'll do in the long run for sure.
I think the treatment data also gives us guidance on that as well. I mean, there's not been adverse events when went direct to inject for treatment, and I think that. So I feel more comfortable given that we have both treatment and prevention data that moving directly to injection is not associated with worsening adverse events.
And by definition, the more emerging drugs that Jean-Michel reviewed, once you give it, it's there, right? So these long-acting drugs with half-lives of several days to a week or two, they're going to be there. So that's just a risk that we have as we use long-acting drugs. A couple of practical questions, Hyman, just about which types of platforms do you use in terms of testing? How do you set it up? If you'd briefly discuss how you go about deciding which tests to provide and how do you keep up with all that?
Yeah, so it sort of depends on what the clinical site has. So some of our clinical sites use like StatPack, for example, rapid testing. Many use the Abbott sort of blood-based laboratory testing. We have the luxury and advantage of having pooled HIV testing in our public health lab here. And so at our clinical sites where there is rapid testing, there can be the pooled testing that's done. A lot of the laboratory elements, I'm the laboratory and medical director at our San Francisco AIDS Foundation. And so there was a desire to have a genius so we could do the entire CDC algorithm on site. And so that took a lot of development to do. But I think using like Quest or LabCorp, or whatever lab testing you have available to make it easier and create as few headaches as possible to just support the testing is generally, I think, probably the best approach.
Yeah. Henry.
No, I think we've reached.
Well, we got 3 minutes. They gave us some extra time, so we can take advantage of it. So I was going to, there is a question that comes up about cost, and maybe since we have a US based and a France based, let's just talk about TDF FTC. We saw earlier in Rafi's talk about $1,800 a month, but generics, one of the chat comments was that it can be down as low as $50 a month in the US for generic. But that means the patient has to pay out of pocket. So Hyman, I'll start with you. The grade A recommendation from the public health service or whatever, can people get the $50 generic? And how is this all paid for, and what does it cost? TDF, FTC?
Yeah, so if somebody has insurance and they go through their insurance for coverage, then there's a zero copay. And so what in the US people will notice is that their TDF FTC looks different, right? So blue is the Gilead color. So most of the generics are now white. And so they just happened a few months ago. And so we actually had some patients concerned that they got the wrong medication because it changed color, but they had no bill. So, people might have a copay for their blood pressure medication, but they will not have a copay for their PrEP. And then, yes, you can get, actually, we have a couple of pharmacies that offer for between $30 and $40 out of pocket. So this is helpful for people who might be on a parent's insurance and don't necessarily want their parents, particularly young people under 26, to know that they're, getting Truvada, so they feel comfortable paying for it out of pocket at $30 a month is something that's reasonable. So yes, it is available at that low cost.
Yeah, Jean-Michel?
Well, that's actually the reason why Gilead has not filed for approval for Discovery for PrEP in Europe. It's because of the generics. We have like 6 or 7 different generic. So we don't call them TDF anymore because it's not a fumarate salt. It's tenofovir disoproxil, and you have different salts that could be combined with FTC. Oh. And so it's TD FTC. Well, and actually the cost can be as low as 10 euros per box of 30 pills. So if you take it on demand, 15 pills a month instead of 30 pills, it comes down to 5 euros a month. So I used to say it's even cheaper than condoms to take pills. That's the main reason why it's going to be difficult for new products to be approved. As long as the cost has to be as low as generic TDF FTC, or to show a better effectiveness. And as you know, the effectiveness of TDF FTC, when it's taken as recommended, is almost 100%. So it's going to be difficult to show a better effectiveness. And even in the cabotegravir trials that Rafi presented, these were double-blind, double placebo-controlled study. So in those studies, for example, people had to come to the clinic to receive their injections, whereas for the pills, they just were given a box of pills, and the people will take or not their pills. And if they felt that they have received a real injection, then they probably were inclined not to take the pills as well as they should be. So that's why when you look at the incidence of HIV infection among MSM with TDF-FTC in the 084 trial or in our study, you see a big difference that probably is linked to this issue of adherence to pills. And for prevention, we know adherence is a key factor. So back to cost. In France, PrEP is given for free, so you don't pay anything. You don't have any copay. So the government gives PrEP for free as long as you have a prescription. So that's why the government is really careful about the cost, and getting other drugs approved will be a challenge, especially if their cost is much higher than generic TDF-FTC.
Yeah. So in France, it's a grade A+, because you get it free everywhere. Henry, I guess that's it for time.
Well, I think if I left it up to Mike, we would probably keep answering questions all through the lunch break. But let's take a break right now, because we do have a panel at the end where we can come back to these. Rafi will be back for that panel, so we can involve him in that. But we're going to take a break now until 1:10 Eastern time, and then Susan Buckbinder will start with a really great overview. So I think this has been a great session, and we'll see you in 20 minutes.